discussion focused on the Ugly Stepsister, so the Cinderella motif. Where would the group like to start? You're up, camera. You're fine.
I guess we can start with the stepsister herself, Elvira, and the journey she goes on throughout the film. I feel like she has an arc.
Yep. So, would you observe?
I feel like she, at least it seems like she starts the film with not really an acute awareness of her appearance, and then she, like, based on the norms that are imposed upon her from family and others, like, develops like an awareness of her appearance and like fixation on that and some disordered eating behaviors.
Mm-hmm. What did you notice or observe with regard to her eating and feeding behaviors?
Well, she follows the tapeworm egg.
Recording in progress.
Lose weight, and she like there's like the scene where she's like looking at herself in the mirror and is like noticing her body, which appears to be like a healthy body weight, but is you can like the way that the cinematography is framed is like she's uncomfortable with that.
Mm-hmm. And with that very observation and how that could influence her self-image, there should be two diagnoses that instantly pop up as a differential and will very likely pop up on your shelf exam. What are they?
Body dysmorphia.
Mm-hmm. So body dysmorphic disorder. What else?
I guess in her case, it's like
disorder,
like eating disorder,
like binge eating.
Which ones?
I don't. It's like I don't know.
I got.
Sorry.
Bulimia.
Mm-hmm.
Oh, we were talking about anorexia.
There's anorexia.
Oh,
yeah.
She doesn't have like she doesn't seem to have purging behaviors like forcing herself to throw up or like excessive exercise. So I would lean more towards anorexia, like a preoccupation with body image.
Mm-hmm.
Unless you make the argument that her tapeworm swallowing is a compensatory behavior.
Yeah,
Mm-hmm.
true.
Yeah. Yeah, I mean, that might be a metaphor for her ingesting either diuretic or ipecac, or right. So, first question to the group: with regard to the observed behavior, do you believe there is a disturbance of body image?
Yes.
Yes. If a disturbance of body image, question: does that support anorexia? B, bulimia, or C, both of the above?
Both, and the difference is, I think, the way that we learn on New World is by BMI.
Correct.
Okay.
Correct. I think, and that could certainly come up 50-50. I don't know if the board is going to spoon feed you and give you both. So let's assume that they're going to go with one or the other. 50-50 chance, body mass index, being underweight. And that'll support which one? Anorexia. Oops, I'm going to throw things at you. Anorexia nervosa. What is the other non-BMI criterion that separates and distinguishes anorexia from bulimia nervosa?
Purging behaviors.
Restriction.
And by the way, since the purging behavior does not differentiate, they're likely to put that in the first sentence. They're going to hope you skip right over, go right to either bulimia or an anorexia, get it wrong and move on. All right, so be very careful about that, right? So,
I think I would think that too, because anorexia has those two subtypes, restrictive and binge purge, where I think binge purge is also seen. That's what you were talking about, right? When you said restricting? Yeah.
right. So that that could be anorexia, right? But I would assume, again, just in prepping for the shelf exam, that the board is much likely to not give you restricting type, give you binge eating and purging subtype, so as to confuse you. Mm-hmm. Relating back to our original question, how then can you differentiate when you're not told a BMI? Because there's a fear of gaining weight despite being underweight. So being underweight is necessary. However, you should actually state the full sentence out loud. There is a fear of gaining weight despite being underweight, and that's where the BMI comes in. Bulimia does not have that fear, and therefore does not have the underweight criteria, and that will help differentiate. So now knowing what you know, what do you think is going on with our patient, with Elvira? Is it A, anorexia, or B, bulimia, or C, neither.
I think she develops a fear, but I also think it's compounded by these external factors of she needs to be in this competition because her family now doesn't have money and all that stuff.
And what a metaphor for the U.S. culture. So I agree. This is probably A, right? It might be anorexia here. There was something else that you brought up that I wanted to mention as well. Now, it's escaping me. It'll come back. Let's talk a little bit about body dysmorphic disorder, since this is also in a differential diagnosis and therefore is likely to appear in your answer set, perhaps choice D. Body dysmorphic disorder is not an eating and feeding disorder. However, it is in our differential, even though it's part of the obsessive compulsive and related disorder chapter. It's a disorder related to OCD. In this case, I think the easiest way to kind of learn or approach body dysmorphic disorder is that, similar to an eating disorder, there is this preoccupation. But in this case, it's a preoccupation with an imagined defect in appearance, and that defect in appearance is not body weight. Because when it is body weight, guess what? We're in the eating disorders differential. So that's the easiest way. So that's why it's related to eating disorders, even though it's not in the same chapter. That makes sense? Give me an example. Not from this film per se, but
Example of what?
body dysmorphic disorder. No. Just how might this present on a shelf, or clinical practice, or both?
Someone, I've seen this question a lot. Someone who is unhappy with their nose or their breasts and want to get a plastic surgery.
Yeah. Rhinoplasty is a very common example. And when the plastic surgeon doesn't believe that rhinoplasty is indicated, they may refer for psychiatric evaluation, and body dysmorphic disorder would then be a contraindication to reconstructive or cosmetic surgery. Why? So again, the question is, upon referral, anyone in this class, because I think I'm looking at all future psychiatrists, deem that the patient referred has body dysmorphic disorder. You furnish a letter, correspondence letter, back to the plastic surgeon. And now that surgery, that rhinoplasty, is contraindicated. Why?
Because their desire to have it is due to an underlying psychiatric condition.
Okay.
Because they also might change their mind in the future, or
So definitely yes.
If it's treated and then they don't no longer might want to have it, and a surgery is a big procedure. It comes with its own risks, but after they're treated for their disorder, or if they change their views, or with body dysmorphia, they might just because you're kind of validating them and kind of reinforcing, and then they might change into being dysmorphic, having dysmorphic views about something else, and then they might want to seek treatment for that, and then you're just kind of promoting that.
Both of those potential outcomes are the exact reason why. The less, this is anecdotal, but the less likely outcome was the first one you mentioned, and that is you're wind up basing your surgery on something that is due to a mental disorder, and resolution of the mental disorder may have the person reflect back and say, I was not of sound mind when I came to you asking for surgery, requesting surgery. That's relatively rare. What is much more common and is much more likely to be the natural history of body dysmorphic disorder is that if the surgery is provided, the preoccupation is just translated or displaced elsewhere. And that's why that's the true reason why, number one reason why it's contraindicated.
Does that go back to capacity?
Yes. Yep. All right, and that's a great point, and I don't know the answer, so I'm going to ask a question. I'm going to tell you from the start. I don't know the answer. I don't know if the actual diagnosis itself, in a letter corresponding back to the referral source, is enough, or if in that letter you must also establish that the patient therefore does not have the capacity to make the informed decision. I would think that it's the former. That is, the diagnosis itself. And the reason why I say that is because if it's due to capacity, next of kin could then authorize the surgery and consent to the surgery, which would be an awful situation to be put in.
Which in this movie, her mother probably would
Yeah,
have.
yeah, right.
Yeah.
All right, so that's body dysmorphic disorder. Any questions about how person comes in, you diagnose body dysmorphic disorder. One of the things your attending catches you on, now you're a resident of mine, one of the things that your Freudian slut attending catches you on is the differential of delusional disorder somatic subtype. Of course, the question that is going to be ping pong back to you very quickly is why not? So what part of the history might support your saying, no, this is body dysmorphic disorder and therefore not delusional disorder, specifically with the somatic subtype? What's the definition of body dysmorphic disorder? Let's start simple.
Having a false perception of what you look like.
That's part of it. I'm looking for.
Preoccupation with your appearance.
I want that a little louder.
Preoccupation with your appearance.
Everybody hear that? What's a preoccupation? Using big words.
It's weird and being fixated and kind of
Occupying too much of your thoughts.
Yeah, that's exactly right. Preoccupation is a maladaptive thought. It's a deficit in thought content, right? Thought content, part of the mental status exam. We often think, and rightfully so, very quickly of suicidal thoughts, homicidal thoughts, also deficits in thought content. Well, there's another deficit called, or under the umbrella of themes. So suicidal ideation, homicidal ideation are thoughts, and then themes. One example of a theme could be a preoccupation, right? That's a deficit in thought content, thematic deficit. Another thematic deficit is the delusion. Difference? They're both deficits in thought content. They're both deficits in thematic, or themes for thematic thoughts. What differentiates them?
A delusion isn't based in reality.
Well, the preoccupation isn't either, which is why you can't get your surgery. But with regard to reality testing, what's true for the delusion that it does not hold for the preoccupation?
Is it? Oh, sorry. No. Is it that it's fixed on one thing? Like.
Yes and no. It's fixed. But it's fixed despite being provided evidence to the contrary.
Okay.
It remains fixed. And therefore, we can deduce that there is no insight.
Okay.
Right? So, delusion remains fixed despite reality testing, despite our providing evidence to the contrary. And therefore, the individual is deemed to have no insight. On the other hand, the preoccupation is not fixed. There is an element of insight that at some point, it may not be your initial eval, but at some point, as a physician, you render the opinion that the individual has insight. So you could hear somebody tell you, again, it might not be this easy, hey, doc, I know this sounds crazy, but I can't seem to get it out of my head. That's insight. Right? And that's the reason why, for all intents and purposes, an obsession and a preoccupation are largely interchangeable in terms of diagnostic labels. They're both deficits in thought content. They're both themes of thought content for which there is some element of insight.
Is it like the somatic symptom disorder? No matter how many times the patients feel you don't have this disease, they'll just keep researching and keep like going from one provider to the other, seeking answers because no insight.
No, there though, you wouldn't call somatic symptom disorder if there was no insight. You'd call it delusion.
Yeah.
Right? So somatic symptom disorder, yes, they're definitely doctor shop, but at some point you'll have to render the opinion there does seem to be insight. The rigidity just is not there, which is the governing principle to the delusion, to the psychotic delusion. Right? Makes sense in terms of delusional disorder, somatic type versus body dysmorphic disorder. One further question, this, only because this might come up on the shelf exam, and if it does and I don't go review it, I feel terrible because it's difficult. So we probably should discuss it. We're going to lose half of our viewers by going down this rabbit hole. In 2013, it is true that the APA did have an additional designation put on body dysmorphic disorder, a specifier saying with no insight. Yeah, after I just told you what I told you. What in the world? So how in the world is a test taker, one of my beloved third-year medical students, sitting in front of that forsaken exam, going to choose between choice C, body dysmorphic disorder with no insight versus delusional disorder, somatic subtype? What's the difference? And I'll give you the answer. I don't want you guys to rack your brains around this. Here's the bottom line. In a slice of time, you are not going to be able to tell the difference. Right? They're going to look exactly the same. However, the individual with body dysmorphic disorder, that preoccupation syndrome, therefore, should have insight. Will have it at some point during their illness, even though it may not be sitting right in front of you at that time. So your diagnosis today may be with no insight, but at some part or at some point during their illness, they had demonstrated insight. And the reason why we want to do that is twofold. Number one is the American Psychiatric Association wanted to reinforce this idea that largely due to psychological stress, preoccupations in general act on a continuum. Right? And therefore, there might be episodic periods of psychosis. Right? Stress-induced psychosis is real. And you have to conceptualize that in a continuum. So with the individual coming in with where their brain is structured, an element of stress ramped up from a 5 to a 9 can result in the level of insight changing. So we have to appreciate that. On the other hand, what the APA didn't want us to do as clinicians is just flip-flop diagnoses. Today you're psychotic and you have a delusional disorder, and 48 hours ago when I saw you last, it was body dysmorphic disorder because you were preoccupied. That doesn't make sense either. All right, so the good news is that at first glance that you're staring at that shelf question, you're not going to be able to tell the difference. The great news is that you know that, and if you read on, if you are provided evidence that at some point during their illness there was insight, since we're not going to continue to change diagnoses on our patients, we'll call the preoccupation syndrome labeled body dysmorphic disorder. Does that make sense? Mm-hmm. And that's that's the most sense I can make of it. Because when I first saw this in 2013, I thought I was going to have to destroy multiple PowerPoints that I was using to teach this topic. All right, back to Elvira, body dysmorphic disorder versus bulimia nervosa versus anorexia nervosa. Any question, any concern about her ingesting non-nutritive substances? I got a quick nod. In what respect?
She literally ate a parasite, so she wasn't giving away. So I guess.
Yeah, and let's say upon, and again, we have to rewrite the script just a little bit. Let's say that upon further inspection, that is but one example of multiple non-nutritive substances this character doesn't, in fact, ingest. Do we broaden our differential at this point?
You could have a vitamin deficiency.
Mm-hmm. Mm-hmm. And, and in what context might that be a consideration?
There's altered mental status.
Is
that what you mean, or no?
No, that's a good point.
I don't know if this was discussed, but like bulimia, where she wants to eat, she said no matter how much I'll eat, I won't gain weight. But then she's using a means to kind of, instead of like vomiting or using laxatives, she's ingesting those things. So.
Yeah, and I do think the parasite is largely a metaphor for those purgatives. Is that a word? Yeah. And I agree with you. On the other hand, let's say that upon further investigation, though, there are multiple attempts to ingest non-nutritive substances. What other conditions should we consider here?
Pica.
Yeah. And within the context of working that up, we have to look at vitamin deficiencies because no mental disorder should ever be diagnosed without investigating potential underlying organic pathology. and that includes substance-induced versus general medical condition, and that is vitamin deficiency would be a medical condition that we have to consider. So that was what I was getting at. Any other questions about any of the eating and feeding disorders? I think it's feeding and eating disorders.
In regards to like when she eats food alone in her room, how would that not be a binge? Because it's usually like I think like after dinner or it's like late at night.
It might be.
Okay.
It might be. I guess I'm going to reflect it right back to you. Why do you care? Why are you asking?
Because I don't know, she kind of like tries to hide it. But I think also like another way is like her mom kind of was like starving her, so I think it was like her trying to like, because she was hungry.
But let's say, for purposes of, again, teasing this out, we discovered that she actually is binging.
Mm-hmm.
Does that change her diagnosis or rearrange our differential?
I think the only part that I'd want to like actually interview her to like get more information is it because of shame or is it because she's going to get in trouble with her mother? You know, I think that would be more important for me just personally because I think I would approach it differently.
Mm-hmm. And I know the answer you're going to get in general practice is that you're not going to get a clear answer. Very often, we might talk a little bit about treatment. The treatment planning is largely going to be predicated on psychotherapy. And even in therapeutic sessions, it may not be that easy to gain those answers. That said, one of the things that we should consider is that if she is found to actually be engaging in frequent binging episodes, it's not likely to change our diagnosis, meaning that if an individual meets criteria for anorexia, they have anorexia, period. If they also meet full criteria for bulimia nervosa, single best answer is anorexia. That is, if they meet criteria for both, anorexia takes precedent. Right? So your observation about her binging, I think, is accurate. Unfortunately, for diagnostic purposes, it's not going to change anything. Anorexia still is the single best answer.
So would it be just like anorexia, but like also like a binging component? Really?
Yeah,
Yeah.
with bulimia, the bulimic subtype, they will binge and then they will use like some sort of means to not let it affect them, whether it's vomiting or for her ingesting the egg. Yes, so it's still.
Yeah, I mean, I think what you're alluding to is the inaccuracy, or I mean, it's the difficulty trying to create artificial categories to describe and encompass human behavior, which is incredibly complex. Mm-hmm. So, yes, believe it or not, there are people who have anorexia that binge and purge. Right? Even though the textbook would lead us to have these really neat categories, and we test you on those categories and pretend that it's real life, and it's not. But again, to the APA's success and credit, they do very explicitly state that if a person meets full criteria for both, it's anorexia.
Okay.
We are 24 minutes after the hour. You have a 12:30 didactic, so we literally have 1 minute. Any final conclusions or thoughts pertaining to the Ugly Stepsister?
So many. I thought it was interesting. This was a very minor detail. When she was holding like the letter or something, the tapeworm egg, you could see she has an excoriation disorder of her fingers. And it was like so subtle, and I was like, I wonder what else is subtle, but I just don't know how to look for it yet.
Mm-hmm.
And I think that also probably relates, probably similar to her disordered eating, such that she's trying to find ways to cope with her situation.
Yep. Yeah, I would almost guarantee there's going to be a third variable, a common variable in terms of etiology. And that relates to and I assume she would be diagnosed with excoriation disorder, and the same if we were talking about hair pulling, and therefore trichotillomania. Both of those conditions are part of the OCD spectrum. So the obsessive compulsive and related disorders. Now we have 3 disorders related to OCD that we discussed: trichotillomania or hair pulling disorder, excoriation disorder, and body dysmorphic disorder. So the fact that we had discussed body dysmorphic disorder in the context of her behavior, it does not surprise me that you observed physical deficits or findings on physical exam that are suggestive of excoriation disorder, and it wouldn't surprise me if she demonstrated behaviors that were consistent with trichotillomania or hair pulling disorder either. All right, 25 minutes after the hour, we nailed it on time. We will be back 1 week. I will post both the movie and the Seinfeld episode within the hour. Okay, thank you guys.
Thank you.